Now, 120,000 more people are getting specialist mental health treatment than they were 3 years ago. But years of stigma of mental illness, both in society and the NHS, have created two doors to the NHS, one for mental health and one for physical health. The 5-year forward view for mental health is addressing this and integrating physical and mental health. So this session is going to bring together the leaders of this transformation, along with experts who have delivered change in their area. Let me introduce our panel. We have Professor Alistair Burns, National Clinical Director for Dementia and Older People's Mental Health, NHS England. Claire Murdoch, National Mental Health Director for NHS England. Paul French, NHS England North Clinical Lead for Early Intervention in Psychosis for the North West. Andy Bell, Deputy Chief Executive, Centre for Mental Health. Dr. Rhiannon, England, NHS City and Hackney CCG. And Fiona Eastmond, Peer Support Worker, Community Mental Health Team, Hillingdon. And let me hand over to our chair, Alistair Burns.
Well, thank you very much indeed. It's a great pleasure to be here to have the opportunity to present what I think is one of the key issues on the NHS, as we've heard this morning, yesterday, and we'll hear this afternoon in terms of mental health. I'm an old age psychiatrist, and it's a great pleasure to be here to hear some of the excitement that there is around general mental health and specifically the interface between physical and mental health. My job as the chairman is merely to keep things on time and to keep people occupied, and so I'm not going to say any words of introduction because you're here to hear from the experts. So our expert of experts, to begin with, it's a great pleasure to introduce Claire Murdoch, who's the National Mental Health Director. Claire, you're going to take us through some of the aspects. Claire.
Thank you very much. Thanks. Thanks, Alistair. Thank you and good afternoon, everyone. I just had to check the watch. I'm losing track of time. Thank you so much for attending this important session. And I just want to set out very briefly. I've got 5 minutes, and I know you're just going to pull me off with a shepherd's crook if I go over, so I won't. But I want to very briefly set out what you already know, what we already know, which is the case for this change, the case for improving integrated physical and mental health care, and just give examples of 2 or 3 things that we're driving at NHS England with partners. But I do want to say that in this role as National Director for Mental Health, I go up and down the country, see a great deal of what people are doing, and I'm so impressed at some of the innovation in this space. I've visited acute hospitals where they have mental health nurses on their wards, but equally I'm visiting mental health services where they're employing registered nurses to help them deliver better physical health care in various settings, and a whole range of initiatives across the country. So people are thinking much more broadly than some of the things that we're pushing nationally. But you know why. Let's move on to the next slide. Just going to, and I love this 2 doors. We thought about getting a graphic, and I wanted people to us to picture a patient between 2 doors and being forced to choose. Here am I? Here we are. So you can imagine, here I am, the patient or the person in need with a serious mental health problem with my cardiovascular system, my diabetes, a whole range of other potential problems. Which door am I going through? Why do I have to choose? When the interrelationship between my physical and mental health is absolute, and the evidence base has been now the case has been resoundingly made by researchers. So why do we still have 2 doors? When, just a few facts and figures, and they're depressing. I trained in a Victorian asylum as a mental health nurse. I'm still a mental health nurse, 33 years ago. And I look back now at some of the practices of 33 years ago, and I think they were really poor. I'm shocked at some of what we thought was cutting edge then, kind care then, and it wasn't. Equally, as a nurse 33 years ago, I would read patients' notes from 20, 30, 40 and 50 years ago and be appalled at what people thought thought was good care then. I believe that this 15 to 20 year gap in life expectancy for people with SMI is our great shame collectively now. I think people 20, 30 years from now will look at us right now doing our best, caring for people, and think, what were they doing? Really, that's a shocking figure. But you know that. And you know that it's circulatory diseases, cancer, all 2 to 3 times higher with people with a serious mental illness. Now, before people die from their cancer or their cardiovascular disorders or their liver disease or other things, before they die from that 15 to 20 years earlier, they've been somewhere, haven't they? They've been living a life. They've been visiting their GP. They've been in the care of mental health services. They've been in the acute hospitals and on acute wards. I must just say that there's some superb work that's been done by the strategy unit, led by Peter Spilsbury and team, commissioned by NHS England, where we've sent a report to every STP in the country, detailing where people with serious mental illnesses are in the acute sector and what they're being treated for. And go, if you haven't seen your STP's report, ask for it. See what's happening in your area. It's shocking. There's a good economic case as well as to why we should do something about this, and Andy will say more about it later. But medically unexplained symptoms, £3 billion worth of services consumed a year. And what are the outcomes? What's the satisfaction? What's the quality of life of people who have medically unexplained symptoms, who are going for multiple physical health care assessments and so on and so forth, who may have underlying mental health issues, which if we treated, anxiety, depression, maybe would cut down some of that $3 billion a year. And also, in terms of emergency admissions for people with physical health care problems, the financial cost is huge. I could say so much more, but we've got other experts who will say a lot more. Some of the things that we're driving through the 5-year forward view for mental health are that we have committed to have 280,000 more people by 2021 who are living with a serious mental illness, having the full suite of evidence-based physical health checks. And of course, it's not just the checks, is it? It's the plan. What do you do once you've made that assessment? What are you doing to key into the GP, into the acute hospital? What are the programs you're putting in place to help people reevaluate life and how they live it and give them some support, whether it's lifestyle or understanding their own illness? We've got sequins, which have run, I think, for 3 years in a row now. We're seeing increase. Definitely more people are now getting physical health checks, rather. But we're not seeing the increase at the rate we want. And I've got Karen Turner, my brilliant colleague, who's director in the national team, going like this at me. Don't blooming well oversell the increase. It's too little, too slow. That's what you want me to say, isn't it? I've said it. It's your blood pressure can come down, Karen. But it's true. It's too little and it's too slow. So we're incentivising local areas. We're paying them through the sequins. We want to see people having the full suite of checks and then plans to follow. We've said that no acute hospital will be without an all-age, and this is terribly important, given how many people in acute hospitals are older people, it's back to the 2 doors, with a complex suite of difficulties, physical and mental health problems often, and our psychiatric liaison services, mental health liaison services, in every acute trust by the end of the 2021 period can make a huge difference in terms of staff training, making sure patients get the follow-up that they need after they've left hospital, as well as when they're in hospital. And the third thing that we're doing is IAP services. Many of you have heard me say on this conference, and you're going to get tired of hearing me saying it, our talking therapies programs, the biggest in the world, we think, of any talking therapies, coordinated talking therapies program in the world, evidence-based, New York Times, the Gulf, Canada, we're the envy of the world. And this past year, we've pushed pilots out now working in primary care, focusing particularly on the use of evidence-based talking therapies for people living with comorbid long-term physical health conditions. Because again, you'll hear from others, the evidence base is clear. If you're suffering from long-term physical health problems, you're more likely to be depressed and anxious. If you're depressed and anxious, you don't look after yourself, you don't walk as much, you don't eat as well, you don't concur with your treatment regime for your diabetes, you get iller physically, you get more depressed and anxious, you get the message. The evidence is clear that if you have access to evidence-based talking therapies through the iApp, you can see a huge improvement in your ability to manage yourself. So these are some things we're pushing at NHS England through the 5-year forward view for mental health. I do think, and finally, because Alistair's getting his shepherd's crook out, that working through recovery colleges, patient education programs, and more peer support can also make a huge difference. We can't do all of this from the centre. I think it's got to be ground up, primary care up, user-led. So thank you very much for listening to me. I'll sit down. Thank you.
Well, thank you, Claire, for getting us off to a great start, explaining the two-door analogy. They're common in mental health, whether it's dementia is a diagnosis that opens doors, or we had the revolving doors, we now have the two doors, so that's fantastic. The soundbite is terms of some of it is shocking. I hope no one tweets, at Expo, Claire Murdoch, shocking. I hope no one tweets that. So, next on my list I have Andy Bell. It may or may not be true. Let's see what the slides say. No, it's Paul French. Now the trick of the chairman is to keep things, Roy. That's the slight danger of over-organising things. Paul's a colleague from Manchester, and Paul, you're going to tell us about issues to do with mental health from your point of view.
Thanks very much. Well, firstly, it's great that there's so many people here who are at a session around mental health and physical health. It's really great to see. You always have that fear when someone's been on before you, such as Simon, you see a mass exodus from the stage. Then actually there's going to be no one left. We thought there was going to be an audience, but it's great to see you all here. For what is an incredibly important issue. Claire's already given us some kind of heads up around the real issues. Real issues around the problem around people with severe mental illness, and that fact about people dying 15 to 20 years earlier is a real injustice in terms of our health economy, a massive injustice. But perhaps the real issue is, as well as that health injustice, which has been that people die so much earlier, is that we've known this for a long period of time. This has been something that's been on our agenda for a long time. We've known that people die early, and yet still lots of the practices are still continuing. These are just the facts. I think it's always important just to orientate ourselves in terms of some of the facts around this difficulty. The headline is clearly about the fact that people have been dying earlier than their peers, this real health inequality that's there. But also we see lots of other issues that perhaps tee into why some people are dying early. The factors of obesity and diabetes, the factor around people accessing healthcare in a slightly different way, and Claire's already orientated us to the fact of this two-door analogy in the way that people get into services. The fact that people access those services in a very different kind of fashion, that lots of people will tend to use more emergency services than a planned way of thinking about care. And yet we have technologies now that actually we can really start to think about how people can get lots of their screening done in a very different kind of way, rather than having to get it done in an emergency kind of way. So point-of-care testing, which we know is available for lots of conditions, is absolutely an important thing that we need to promote in terms of people with psychological conditions. This was an algorithm that we were encouraged to steal from our Australian colleagues. And this was a way of starting to categorize why people with severe mental illness were struggling with some of their physical health conditions. And what it started to do, and Claire's already given us a heads up, that actually it's important to screen people. It's important to get a sense of trajectory of where these problems start to come from. And this algorithm started to give some direction in not only the important things that we must screen, but what sort of levels we need to look out for if people are starting to struggle. This was termed the Leicester tool. This was based on Helen Lester, who's a great colleague who worked in Manchester and Birmingham, sadly who kind of passed away a couple of years ago. But Helen was instrumental in bringing this tool over to the UK and rebadging it for the use in the NHS. But one of the things that this has done, and has done incredibly well, has absolutely got lots of people screening, and screening incredibly well. And when you go around and you ask people, how are you doing with your screen? Well, I've measured lots of things, Paul. So how are people doing? Are people at risk of diabetes? Well, I'm really not quite sure, but I've done the test. I've done those tests, and I can tell you we've ticked all the boxes to do the tests. NHS England have kind of moved further. They've really started to take the bull by the horns here, and they've taken an incredibly brave kind of way of managing this through the sequin process, that now what they're incentivizing is not just process, is not just the fact that people are having all of these routine tests done, but they're now starting to look at outcomes, looking at how many people are actually struggling with diabetes, how many people are putting on weight, how many people are starting to put on weight. And some of the latest sequins are absolutely targeting that early weight gain that we know is prevalent with people with psychosis. We're really starting to move towards getting things absolutely right from the start. This was a leaflet that was done locally through Greater Manchester West as it was, and it was done co-produced. It was designed and kind of formatted, and the kind of all of the language was developed with people who use our services. And what they were absolutely keen about is that we start to get physical health messages in alongside the psychological messages right from the start. And that's what the new sequins that NHS England have started to help us deliver, that we're starting to get things right at the start, and that we're going to be kind of tackling weight gain right from the beginning. Those are some of the key points I wanted to make. I guess we have the importance of early intervention in psychosis services, which have transformed the way that we deliver care for people with early psychosis. We're now seeing people get access to services within a 2-week time frame. We used to measure delay in getting access to services for people with psychosis in terms of months and years. Now we're measuring in terms of days and weeks. And this, right from the start, psychologically and physical health, is absolutely the forefront of what we do. Thanks very much.
Yeah, great. Fantastic. Thanks very much indeed, Paul. So the challenge of the sequins we have, changing them from process measures to outcome measures to make a real difference, and very good examples, Paul, about how to capture the imagination and make sure that we do that correctly. So we now welcome for the second time Andy Bell, Deputy Chief Executive, Centre of Mental Health. Andy, you're going to tell us about the economics, and I could just say we'll have some time for questions and discussion afterwards. So just going to have the presentations one after the other. Andy, over to you.
I'm definitely ready for this. So I wanted to tell you a little bit about the economic evidence around why we should be supporting mental and physical health across the boundary and all the different boundaries there are between them. Before I do that, I want to emphasize, as we do in all of our reports, that the reason for giving economic evidence is not so you can commodify people and put numbers on people's heads, but so that you can demonstrate the real importance of doing the right things for people and the value for money that brings to the NHS. And the reason for a health intervention is better health, not in order to save money. So that's the preamble. I'm going to give you the biggest number first. So we know from good evidence now that roughly each year the NHS spends about £14 billion on mental health care. So that's money you in your local area spend on supporting people's mental health. What we now know is the NHS spends about the same again on not treating mental health problems, on the consequences of untreated mental health difficulties in terms of people's physical health. So this is a huge number. This is a huge amount of money that could be spent better to save lives and improve the quality of people's lives. This is the reason There's a huge overlap between mental health problems and physical health problems in the population. This is a neat infographic we produced from one of our research reports. And this encompasses all sorts of different relationships. So it's people that have diabetes and also depression. It's people that have psychosis and they're also putting on weight. It's people who have medically unexplained symptoms. It's a massive group of people, about 4.5 million in the whole of this country. And the costs of that are considerable. So for someone who does have a long-term physical condition, or 2 or 3, who also has depression or anxiety or another common mental health problem, the cost of that healthcare rise by 45% just for that one individual person. So it's a massive amount of money the NHS is spending on making very little difference to someone's quality of life. In terms of hospitals, what this means is that for your average size hospital, I know there's no average hospital, but on average, across a reasonably sized hospital, that's £25 million of extra money spent, again, on giving people worse care. The good news is if we have liaison psychiatry services and fully functioning liaison psychiatry services, as Claire mentioned, when we get those, we reckon each hospital can save about £5 million a year and indeed give people a much, much better experience of that hospital. And it does have to be all age and it does have to be in all departments. This is not an emergency service. It's not just about A&E, it's about the whole hospital, really important. And that's where you get the biggest savings. But most people spend most of their time not in hospital. So for people with long-term conditions, we think there's a real case, and it's yet to emerge, but there's a real case for something called collaborative care approaches, which is integrating mental health support within physical treatment pathways. That is psychological therapies, but it's also much more. It's about case management. It's about accepting the fact that many people who have both mental and physical health problems are also poor, living in very difficult circumstances. They need social support, they need economic support, they need help with family and housing and all sorts of other things. There's a big role for the voluntary sector in there. The economic evidence in this area is emergent and it's small scale at the moment, and I hope that there are some STPs out there who will be willing to give this a real try and really test this out and see if it works at scale in this country, because that's what we need to do. Medically unexplained symptoms, they've been talked about already. Again, we know the cost is £3 billion of that across the country. This is a huge number of people going in and out of A&E, having terrible, terrible experiences, and going into having outpatient tests for all sorts of things, and it never quite works. We had a look at a fantastic service in Hackney, and we've got a colleague from there, so I shan't say too much about that was really providing proper psychological support and help for GPs in supporting people with complex needs, including medically unexplained symptoms. The results we found were incredibly impressive. We think this needs to be available everywhere, this kind of approach. Finally, I can't do this talk without talking about the biggest health inequality of all. I saw some tweets this morning about the inequalities between different areas of the country. Where you live 3 or 4 years fewer if you're from here rather than from down south. Well, this is 15 to 20 years, so it dwarfs those regional inequalities we all go on and on and on about. You provide smoking cessation therapy and it works for someone, you buy 7 years of extra life. I don't think that needs any other numbers, does it, to explain the benefits of that. And we want to help really move this forward and make things happen in this space. That's all from me. This is a report we produced which has lots of these numbers in it. I've got about 10 of these in my bag, so come and see me after if you want one. When they've gone, they've gone. And thank you so much for listening.
Thank you, Andy, very much indeed, and fantastic to put some numbers as well as reminding us it's those improvements that help. Andy, is it true to say they're for sale in the foyer, or is it first come, first served? Yeah, an economist hadn't thought of something. How much is that? My day is complete. Andy, thank you very much indeed. So our next speaker is Dr. Rhiannon in England, GP clinical lead for mental health in children. And Andy, I couldn't be reminded that on your slide you did say some of the biggest savings were from older people. We'll come back to that later. Rhiannon, you're going to tell us about your perspective as a GP lead.
Yeah. Hi, everybody. I'm a GP in City and Hackney, and I'm going to tell you a little story about medically unexplained symptoms. As Andy said, we developed a service in Hackney, and I'll tell you why, really. So, if I can get it to work. Yeah, there we are. So MUS, which is medically unexplained symptoms, is a bit of a paradox, really. We talk a lot about the inequality of health provision in mental health. So people with severe mental illness, as we've heard, dying earlier than people who don't have severe mental illness. There's a lot of people in the NHS that are getting too much physical intervention and not enough emotional intervention. And as a GP, I see a lot of people who present with physical symptoms. We all somatize. You know, am I standing here now with a bit of tension headache? I certainly am. Do I have a brain tumor? No, I hope not. Do I get diarrhea? Well, I used to before exams. Do any of us? Yes. Does that mean we have bowel cancer? No, it means we're stressed. But we present with diarrhea. So this is a normal thing, but when it gets into people getting massive amounts of over-investigation, it is shocking, really. I was at a frequent attenders group at A&E a few years ago when we set it up, and we were talking about a 27-year-old man who had presented about 15 times with chest pain in the last 3 weeks. And every time he got an ECG, and every time it was normal. And then nothing happened much. He was given a bit of paracetamol and sent home. And I said, did anyone think about his mental health? Did anyone ask about anxiety? Well, no, we're an A&E. You know, we did the necessary. Anyway, what we did locally was, a good few years ago now, we managed to get some money, which was great. And we commissioned a service. PCPCS is the worst name ever, Primary Care Psychotherapy Consultation Service. Don't blame me, I'm just the commissioner. They chose the name. Set up to help GPs manage medically unexplained symptoms. So it was very tight. We said GP referral only. Nobody else could refer apart from us. It had to be delivered in primary care. They had to be able to engage people that traditionally actually don't want to talk about their mental health. They only want to talk about the next MRI, and often with quite an adversarial relationship with GPs, because I'm kind of saying, no more MRIs. What about this nice person here? They're saying, no, I want the MRI. I mean, that's a caricature because people don't do that, but it is a bit of translation needed to get people to accept to see the service. So it says there what they provide. So have they been any good? Well, the joke, our little sort of local joke in City and Hackney, Hackney is a very deprived area, was that the provider who won it was the Tavistock, who, from a Hackney perspective, were based in Hampstead. So the joke was, would they be able to find Hackney, let alone do anything? And yes, they have. They've been a brilliant service. As Andy says, the Centre for Mental Health have done an evaluation, very beloved of GPs, because they provided a service when I had tried very hard to get mental health trusts interested in helping GPs with primary care mental health. And it was, well, why are you referring these people? What's the diagnosis? And I'm a GP. I said, well, I don't know what the diagnosis is, but I don't want to keep referring them for pointless physical tests. Perhaps there's something going on. So what have they done? Well, as I said, they're massively popular with primary care, and that's all our 43 practices, some of whom are not very psychologically minded. And they have managed to infiltrate and change the culture. So big cultural change for us locally, big cultural change between primary care and secondary care. The service attends the frequent attenders meeting, which is a multi-system meeting, so we get frequent LAS callers, 111 callers, crisis line callers, A&E attendances, and we try and look at the whole system, and they're part of that. And A&E no longer say, well, I've done the 10th ECG, they say, let's think about our psychiatric liaison service or the TAVI service, or let's ask what's going on. I think it's been a massive cultural change for us locally. We all now talk about physical and mental health better. I mean, there's a huge way to go. Of course, so they're a victim of their own success, of course. We've got a big waiting list now. And outcomes, well, that's an interesting one. The patients love the service, the GPs love the service. Do patients recover? well, you know, it's the bane of my life is recovery as it's measured, because no, they don't. And I don't think many MUS services have good recovery rates. The patients show very improved outcomes, but in the strict recovery terms, no. So what we're going to do about that, I don't know. I think the biggest thing, as I said, has been the cultural change for us. Everybody can talk about MUS now. GPs aren't scared about talking about it. A&E isn't, secondary care providers, primary care providers, and people are getting more appropriate help. There's the economics, as Andy said, but actually what matters is people get good clinical care. And, you know, just getting a whole load of bits chopped out of you is very poor clinical care. That's all I want to say. Thanks.
Thank you very much. Fantastic. Well, thank you very much. A fantastic example of a service that really meets a need, but not only raises the profile and changes attitudes and changes perceptions, and perceptions is something that is so important. So we are keeping time, which is great. Our last speaker, Fiona Eastmond, is a senior peer support worker from Central and North West London NHS Foundation Trust, a trust where many good people come from. Over to you. Over to you.
Hi, everyone. It's very big in here, isn't it? It really is quite large. My name's Fiona, and this is cool. I am a senior peer support worker in Hillingdon, one of the Central and North West London places that we cover. I work in the community team, and I supervise 3 peer support workers, one in inpatient, one in the community, and one, I think, the only peer employment specialist that there is. I use my own lived experience of recovery to help others. My ex-diagnosis was borderline personality disorder, so in order to continue to break down the stigma, I'd just like you all to know that. I use the clinical system. I have a caseload, and I work alongside professionals to engage people in their own recovery. And there's a lovely quote here: peers employed in support roles are usually further along their road to recovery. And I am, as you can see, reasonably far along my road, and so that they're able to offer images of possibility. So I thought I'd bring you some images of possibility. There they are. What do I actually do each day? I often see individual people, and talking of the 2 doors to mental and physical health, I do talk about people's physical health, because I've had to look after my own physical health in order to look after my mental health. Some specific things that we've done in our community here. Right at the top there, we've got growing vegetables in an inpatient unit. So it was all in very kind of safe plastic pots, and we couldn't have bamboo sticks and all kinds of different things like that. There was all sorts of, you know, garden-related issues. But our wonderful peer support worker, Murdoch, who works there, has been growing, and now they're eating the vegetables that they've grown. And when the patients come out of that unit, they're going to come round to the allotment that I've started up in the community, and start growing some vegetables. You can see them there against the background of my lovely computer keyboard. That was one of my service users very proudly bringing me some vegetables from their allotment, which was just fabulous. The painting there was done in a craft group that I started. We had several different crafts, and it has now carried on in such a way that I'm having service users approaching me saying, when can I start a new craft group? Not what are you doing for me, or when is this next thing happening, but how can I help you start a new craft group? And that's what I want. You know, I want people to be taking charge of their own recovery, to be taking it into the community, and to be starting wonderful things. Just because you have a mental health difficulty, it doesn't mean that you can only ever be friends with other people who've had mental health difficulties, you know, even though they are the best kind of people. We've also got here, this was another offshoot from the craft group. This is the railings outside the community mental health team where I work. completely covered in crochet that was done by one of my service users. And there's some more crochet on the trees, and there's some giant dream catchers and things. And it just looks a tiny little bit less depressing, you know, outside now, which is great. And that particular service user, when they're mentioned, instead of people saying, oh, they now say, oh, the crochet, which is just fabulous, you know. They're a part of their own recovery, put their stamp on where they spend a lot of time, you know. What else is up here? This is one of our local cafes, because I like to try to situate recovery in the community as much as possible. And they're a mental health friendly cafe, and we've got a relaxed art group. Now, the art group ran yesterday, but I was here. So my service users ran it themselves, and that's how I want it to be. I want them to carry on doing what they do in the community. And people come along in the park with their dogs, and they come along and say hi, and they might sit down and pick up the pens, and there we have a community group doing what they need to do in the community. We no longer have a little set of ill people doing special things for ill people. So, there's some more of what I do, standing next to flowers. Peer support workers add a unique value to teams. It's not a soft job, it's a very, very difficult job. It is not kind of, you know, just jobs for ill people and stuff. It really demonstrates a real full recovery to be able to bring something back. And it's almost like magic, the way that somebody who's been through something can engage somebody who is just starting on that journey. It's very, very difficult to recover from mental health difficulties. There's a lot of work. You know, it's an unseen illness. There are all those unexplained medical symptoms and things. And it's so difficult to be told by a doctor wearing a suit that it's all in your head, because honestly, that's never going to go down well, is it? So yeah, we bridge the gap, really. And I'm incredibly proud to be working in Hillingdon. I've got some of the best peer support workers in the country, I believe. And they're doing some seriously amazing work. And yeah, I guess I'd like to finish by saying that above all, peer support work should be paid. And that is my main point of today. Thank you very much.
Brilliant, brilliant. Thank you very much. Brilliant. Thank you very much indeed, Fiona. So you've brought things to a fantastic conclusion, and you can tell by the expressions in the audience and the smiles that are going well. One of the things about hosting one of these in a number of areas is that you always listen jealously to the whoops of delight and the applause in other areas. So I wonder, could you join me in giving a fantastic laughter and round of applause to all the speakers? Hooray! So hopefully that will mean that the people on the other side, what were they doing in that mental health session? Wow, mental health's really fun. So we've got a few minutes. I've got a minder at the back who's going to remind me when we've got a few minutes. So we've got 5 minutes or so for discussion. I think we have a couple of microphones, but now if you don't get a chance to ask your question, the speakers will be happy to stay around afterwards. Andy, could I just ask you a first question? In terms of the saving, just while we get the microphones to everyone, could you put your hand up and promise I'll see you? In terms of return, Andy, what kind of rate of return? Because the economics incredibly powerful. Can we talk about rates of return as well?
We can, and the evidence is greater in some areas than others. So the one it's clearest on is liaison psychiatry. And we know that if that's done well, you get back probably about £4 or £5 for every one you put in. It's a huge, huge saving. In many of the other areas, it's about reducing demand on services. So in City and Hackney, we found that there was a return in terms of fewer people going to outpatient departments, fewer people going to A&E. So it reduced costs in other areas.
It's about 4. So if I gave you £5, would you give me 20?
If I could get to my wallet right now, I definitely would, Alistair. I promise.
It's a good chance. Good chance. Right, we're on to the questions. Could we have quick questions and, more importantly, very quick answers? A chance to see people after it. Yes, madam.
Hello, hi, my name's Elaine. I work for a pharmaceutical company. The question I've got is, obviously we know there's a massive gap for people with severe mental illness, but yet when you look at the treatments that are used, there's a very, very high use still of antipsychotics that cause significant weight gain. So and when you speak to service users as well, this is the thing that they always complain about, that they don't feel engaged in their treatment or their treatments aren't reviewed regularly. So I suppose the question to all of you is, how can you change that when a lot of psychiatrists say we always treat mental health first and we don't consider physical health?
A very easy question to ask for all the audience, and I just wonder, that might be something, but does anyone want to volunteer a quick response to a very important question?
I don't mind.
Yeah.
Oh, gosh, that's a bit loud. I totally agree with you. I think locally what we're looking at is a very much more stringent approach to review. I think mental health needs to move like physical health, in that we get letters from physical health consultants saying, do this, this, and this for 3 months, then this, then stop. And mental health, it was, here's your olanzapine, kind of cheerio. Often, not always. And what we're asking for is the same level of detail of review, dropping dose, changing, stopping. As I totally agree, it's a huge problem.
Okay, Rhiannon, thank you very much. A question here. It's the same question, fantastic. Question here, sir.
Tony Johnson, Health Watch, Stockport. I'd like to know whether you are recommending maintaining separate mental health trusts, and I'd like to know to what extent that the trust should be accountable to Health Watch and other individuals. Because what I want to know is what the waiting times are. I want to know the teams, the numbers discharged. I want to have a complete history of what actually is going on. So, because there has been resistance, in Stockport to providing basic information.
Okay, that's very helpful. Claire, do you want just to say something very quick indeed about separate trusts, and then we don't have time to go into all the Stockport figures in the dying minutes, but we can get some information afterwards.
Two things. So firstly, I absolutely don't think that structural reorganisation is the starting point for better and more integrated care. I've certainly worked in acute trusts in my time that ran mental health services, and believe me, they were no more integrated than they are through separate trusts. I think we have to come right into primary care and the level of the patient and work backwards from there. And partnership working will always be a feature in mental health. We all have to get much better at managing those interfaces, which I believe we do once we start to take the whole person care seriously. Just on the should trusts be accountable to Health Watch, I just want to say yes, they should.
Okay,
and
excellent.
certainly what we're publishing in the dashboard, CCG by CCG at NHS England, is our attempt to put into your hands, and we're refining it year on year, but information about waiting times, access standards, outcomes and investment at CCG and STP level, because accountability to our public, to Health Watch, to MPs, to user groups and our commissioners is paramount, whichever kind of trust you are.
A very important point. So it will be published and it is there in the public domain. Sir.
I'm Ndesi, mental health activist from Bradford. I created my own non-profit organisation. My father has bipolar, diagnosed when I was age 13. I have my own mental health condition and I manage it by my lifestyle. I'm studying a master's in psychology of sport and exercise, and there is a connection between the cognitive, behaviour and emotion. We need to look at children's mental health first, primarily, because if we look at the children's mental health, it stops it escalating in the future. So my question is, what is going on with the children's mental health services nationally, and especially with young carers?
I think a very important question, and one that we might have to take offline afterwards, but if you stay, we'll make sure that we get someone to speak to you and give you some information about that. A question right over there, and then we're just in the dying moments.
Samir Jaraj, Race Equality Foundation. So several years back, the Bradley Review found that black and minority ethnic people are 40% more likely to access mental health via criminal justice than via primary care. What do you feel are the major steps that need to happen in order to address that?
Yep. Andy?
We've produced a recent report looking at what's happening to young black men, particularly during their teenage years, that is moving from the fact that age 11, black boys have as good mental health as white boys, but by the time you get to your late teenage years, you've got very much poorer mental health and very much poorer experience of services. What we've said is we need national coordinated action on this. We need something like the Concord Act we've had for crisis care, and we've now got prevention for race equality in mental health, and we want to see real leadership from government on this, but it has to support local action, and the solutions have to be co-produced, working with communities and community groups in schools, in youth work, and youth work has been completely devastated in recent years. I mean, that's incredibly important to mental health. There's an enormous amount to do in that space, and we need to get on with it.
Okay, Andy, thank you. A very good question, good answer. Madam, and then a question here, and then...
Ann Greiner from the Patient Centered Primary Care Collaborative in the States. Agree that we need to integrate mental health into primary care. Collaborative care is a great model. In our system, we don't pay for that, and that is a real problem. What do you do here, and how are you making progress?
Again, I just wonder, that might be a bit of, we are just in the dying moments, it might be an iterative conversation, maybe to have over a cup of coffee afterwards, but great to learn from experience abroad. Question there?
Hello, Judy, Able Policy Connect. Just wondering, in a more sort of esoteric way, is it time we stop talking about mental health? Because people don't, if they've got diabetes, they don't say, I've got a physical health problem, so I've got diabetes, but we constantly use this umbrella of saying people have got mental health issues, illness, and it sort of could be a bit depersonalizing. Is it time to talk about emotional well-being, particularly as people like psychologist Peter Kidman say, a lot of people's mental health illness is caused by childhood trauma, other things like that. So we need to change the terminology to set people free from the stigma.
I think that's a challenge for us all, which is a point that's well made. Any final... Karen, can we just have one at the front, and then we've a minute at the back, madam? There's someone who said that she was going to come and get me at 10 to 1. She hasn't appeared yet, so let's keep talking. Karen.
Hello. Very keen to hear a bit more, just a sentence or two from Paul on why it's so difficult to do the tests that are in the sequin. Why is it so difficult in our inpatient mental health wards to get really good support to give up smoking and diabetes? The sequin results really are shocking on inpatient wards. If you think we're in year 3 now, we're trying to hold on to it, but they need to be going up and up and up, and they're not going up and up and up fast enough on wards. Why?
So a sentence, Paul, really on why, and then we're going to have to draw it to a close. Paul.
Well, I agree, it's absolutely shocking, but the sequin's absolutely going in the right way. It's challenges us more and more, and I think we need the sequin to continue to challenge us. I think the difficulty is that inpatients are not structured in a way that do prioritise people's physical health conditions. They're, because of the nature of the way our kind of inpatient units are now, the people on there are incredibly kind of poorly psychologically, and I think that what happens is that our services focus on getting people kind of psychologically well, rather than really thinking about their kind of physical health care. I'm not so sure our inpatient wards are necessarily the focus. Most people are in community care. Most of the people who we work with kind of psychosis, schizophrenia are in communities, and that's where we should focus.
Thank you very much. So thank you very much. We said we'd talk about perception, and we'll end with an issue on perception, because we all agreed that perception is issue. Perception's an individual thing, and my perceptions were challenged recently. I was on holiday in Scotland, and I was driving round the road, and suddenly round a corner, it was one of these narrow Highland roads, round the corner, a car came fast on me, driven by a young woman, an open-top car, swerving from side to side, and as we passed, she was going so fast, I nearly went off the road, and as we passed, our wing mirrors clipped, and she looked at me and she shouted, "Pig." I thought, oh, that's not very nice. And I drove round the corner and drove into a pig. So for me, my perception was challenged, my perceptions were there, and I think we've heard today. I'm very interested to see how that came out on the translation, for example. Thank you very much to the speakers for a great session, and thank you very much for taking part. They'll be here afterwards if there's any final questions. Thank you very much.